Did you turn on the other one?
Yeah, this one.
Is the green light on?
Yes.
Yes. What about the other one? Is that it? Okay.
And the other one is. Yep.
Whenever you're ready and he's ready, just go ahead and introduce yourself.
All right. I'd like to thank everybody for attending, and thank you for the opportunity to speak. I'm Kenny Murray. I am the Director of Palliative Care here at St. Vincent's East. And again, I really appreciate the opportunity to talk to you today. First things first, I have no financial relationships to disclose, and I will be discussing no non-FDA approved or off-label indications. I'd like to start out with a quote from the Assistant Director General of the World Health Organization that really exemplifies what we do with palliative care. Everyone has a right to be treated and die with dignity. The relief of pain, physical, emotional, spiritual, and social, is a human right. And that encompasses the comprehensive spectrum of care we seek to provide with palliative care, identifying patients' needs and aligning our treatment plans and goals with those needs. So what I'd like to talk through today is what palliative care is and why it's important, when palliative care is appropriate, talk through how patients can benefit from palliative care, discuss the 3 domains of patient wants, discuss some important considerations in goals of care discussions, and then summarize briefly the ethical and religious directives of the Catholic Health Services, specifically as they apply to palliative care. When talking about what is palliative care, it's most important to talk first about what it isn't. And what it isn't is end-of-life care. Palliative care expands the spectrum of care to all people with serious illness. It's specialized medical care aimed at people with serious illness across that spectrum of illness. It's focused on relief of symptoms, the primary one of which is pain, and also the stress of serious illness. The goal of care is to improve quality of life for the patient and their family, and that care is provided by a multidisciplinary team, including physicians, nurses, pharmacists, social workers and case managers, therapists, nutritionists, and especially here in the Ascension system, our chaplains. Participation in palliative care requires at all phases a change in the philosophy of care on the part of the patient and their family. As they transition toward the end of their life, that care changes from supportive to, from curative to supportive, with the goal of treating physical, psychosocial, and spiritual problems. Palliative care intends to neither hasten nor postpone death. It provides relief from pain and other symptoms, as we discussed. It affirms life and regards dying as a normal process. It offers a support system that allows patients to live as actively as possible, focusing on quality of life until their death. And it offers support for families during their illness, also after death, during the period of bereavement. It will enhance quality of life for these patients, and it may influence positively the course of their illness. It's also applicable early in the illness. While these patients are undergoing therapies intended to prolong life, while they're undergoing chemo and radiation, they can still have palliative care aimed at controlling symptoms, aimed at making them feel better with their serious illness. They can still have diagnostic tests, they can still have studies to figure out what's going on, why they're having the symptoms they're having, all with a goal of making them feel better, making them do better. It doesn't mean that we stop doing stuff. It means that we align our treatment with their goals of care. Palliative care also reduces the cost of hospital admissions that do occur, coordinates the patient care, again, and aligns goals with the care provided, or aligns the care provided with the goals of the patient. In the U.S., there's a very clear delineation between palliative care and hospice. Hospice is, of course, a subset of palliative care, but hospice is appropriate when patients who have serious illness are reasonably expected to have less than 6 months to live. And at that point, they transition from those life-prolonging or curative measures that they may be undergoing, even if they are participating with palliative care, to fully symptom-directed therapy with an understanding that they are in the last phase of their life. When we think about hospice, one of the most striking things in America is how long patients are on hospice. Looking at hospice statistics for the U.S., almost 1.5 million patients in 2016, which is the most recent year we have data, were on hospice for that year. 48% of Medicare patients who died received hospice services. The most common diagnoses, and to clarify, that's 48% of Medicare patients who died were on hospice at the time of death. That does not include patients who might have received hospice services, gotten admitted to the hospital, revoked hospice, and then died. Those would not be counted in that number. So that number may in fact be higher. The most common diagnoses, as you might expect, cancer, cardiovascular diagnoses, dementia, respiratory diagnoses, and stroke. The average length of stay for hospice patients, 71 days. The median length of stay, 24 days. But 28% of patients enrolled in hospice were on hospice 1 to 7 days. 55% of patients enrolled in hospice were on hospice for less than 30 days before their death. If the average is 71 days and over half were enrolled for less than 30 days, a lot of patients were enrolled for quite some time, a lot longer than 71 days, to bring that average up. But more striking is those patients who are on hospice for a week, 2 weeks, 3 weeks, who derive a very short time of hospice services. One of the most common things we hear from families who have hospice experiences is that they wish they'd known about it sooner. They wish someone had told them about it sooner. They wish they'd gone on hospice months ago, weeks ago. It's something that they wish they'd heard about before they did a lot of the things they did with aggressive care at end of life. And that's a very common theme we see, and I'm sure all of you see. When we think about patients who are discharged from hospice, 83% of patients discharged from hospice in the U.S. die. 6% revoke their hospice, whether because they decide they don't want to be on it anymore, or whether because they get admitted to a hospital. 6% graduate, so they get better. The remainder of patients who are discharged from hospice either transition to another hospice, move out of state, or get kicked off hospice for whatever reason, but that's a small percentage. Where do these patients die? 45% of patients who are on hospice die at home. Compare that to 20% of patients outside of hospice patients. 20% of patients die at home in the general population, 45% with hospice. 33% of hospice patients die in skilled nursing facilities, 15% in inpatient hospice facilities, and 7% in the hospital. But most of the hospice care, the vast majority, 98% of hospice care days, are provided at home. That's remarkable. The American medical system has struggles, but hospice is something that we figured out a lot of stuff that works. There are certainly issues, but 98% of hospice care days provided at home is remarkable. The average annual spending per hospice patient is $11,820. Compare that to average cost of a day hospitalization, somewhere around $1,400. $12,000 a year to take care of these hospice patients, to provide them quality of care, manage their symptoms, increase their quality of life. There are in the U.S. 4,832 hospices, again in 2016. Most of those hospices are less than 50 patient census that they take care of at a time. So most of them are small hospices, and I think we see that in our Birmingham market. I'll be interested to see over the next few years how that data changes, because we are seeing a lot of consolidation in the market across industries, but in hospice industries as well. So why is palliative care important? People die. Millions of people die every year, and we're dealing with the same causes of death we were 50 years ago. Cardiovascular disease, cancer, stroke. Our treatments are better. People are generally living longer, but the outcome is the same. At the end of the day, people die. It's often said that palliative care is designed to give patients a good death, but there's no such thing as a good death. Death is inevitably filled with sadness, grief, and loss. What we seek to do is create a better life with illness and create a better death for the patient and their family than if we hadn't been involved at all, even if just a little bit. There's also a financial case for palliative care. Palliative care models reduce healthcare costs without shortening life, and in some cases extend it. This only works, though, with appropriate screening for palliative care patients and early involvement. Palliative care models have been shown to decrease emergency department visits for patients with serious illness by 30%, decrease admissions by 28%, increase life expectancy, and decrease healthcare costs by up to $18,000 per patient per month. How do they do that? By aligning care received with patient goals, by making sure that patients are receiving the care that they want, and most importantly, not receiving the care that they don't want. We see that 5% of the population spends about 50% of healthcare dollars. For Medicare patients, 25% of Medicare costs are spent in the last year of life, and half of that is spent on hospitalizations. To some degree, that's expected. We get sicker at the end of our lives. More healthcare dollars are going to be spent at the end of our lives, but a lot of that care does not align with patient goals. Here we see data from a VCU study looking at end-of-life hospitalizations, or looking at hospitalizations globally, showing that end-of-life hospitalizations are longer and more costly. What this figure shows of Medicare deaths, which represented 4% of the patients in this study, and Medicare high-risk survivors, which are patients that they expected to die. Those represent 16% of the cases they saw, but they represent the entirety of a $6.6 million loss. Sorry, I lost my place there. $6.6 million loss during this study period. For the patients that they didn't denote as high risk, they actually made a profit. Even though the reimbursement per case was higher in the sicker patients, it was outstripped by the cost of care. So in those patients who died, or those patients who were critically ill, palliative care may have been appropriate in all those patients. That's where their substantial loss came from. On the other patients, the patients who they didn't deem high risk, they made a profit. Patients also who are critically ill, more likely to readmit. In the era of value-based purchasing, triggering readmission penalties has financial implications as well. What this figure shows, and it's a little difficult to interpret, but the straight up and down lines are CHF patients. The horizontal lines, that's the word, are cancer patients. You see in the last 6 months of life, from left to right, healthcare costs increasing. 6 months, 5 months, 4 months, 3 months, 2 months, 1 month. As they near the end of their life, their healthcare costs increase over and over and over again. This is a trend that's often difficult for hospitals to appreciate because we look at things in terms of DRGs. And if you look at CHF DRGs globally, this trend may not appear. If you look at them over time in patients who die, this trend is clearly apparent. And I suspect we see that in our patients if we looked at them structured this way. But it certainly supports what we expect to see, that as patients near the end of their life, the cost of their care increases. So here what we see, and this is, again, not as big as I'd like it to be, but the takeaway is that the top line, which shows healthcare cost associated with patients that had no palliative care involvement. The other three lines indicate palliative care involvement at 7, 10, and 15-day intervals. And you see that the sooner palliative care gets involved, the sooner reductions in healthcare costs start. We see healthcare reductions in cost at each moment that palliative care is involved, but those reductions are more dramatic and lasting the sooner palliative care gets involved. This is another series, 2 lines, one with non-palliative care, one with palliative care in the days prior to death, counting down from 10 days prior to death to 0. At the beginning of the period, the initial gap between those two cases is about $400. At the end of the study period, that gap is nearly $1,000, somewhere around $800. Still a substantial difference in care provided by the reduction in resource utilization for palliative care patients. Back to why it's important, outside of the financial case, patients don't want it. We're giving them care they don't want. In the last month of their life, 50% of patients visit the ER. 75% of those get admitted. And of those, 75% of the 50% who visit the ER in the last month of their life, 2/3 die in the hospital. Most of those in the ICU. Most people, 80% or so, want to die at home. But a lot of them are dying in the hospital. They're dying in a place they don't want. They're getting aggressive care they don't want. When we think about why is that happening, because the conversations about what they want, how sick they are, and how likely the things we do are going to help them aren't being had or aren't able to take place because the time that it comes to mind, they're too sick to participate. When we also think about the impact that these things have on patients and families, there are a lot of things that we can do to people. As patients near the end of their lives, living with serious illness, the list of things that we can do for them becomes much shorter. And what we should remain cognizant of is that what we're here for is to do things for the patient, and everything that we do should be doing something for them, not to them. And as those lists change and as those priorities change, so too does the aggression of the care we provide. People who are very sick often have family members participating in their care, especially here in the South. 50% of households in America serve as unpaid caregivers, mostly women, spending 20 hours a week or more. A quarter of households spend more than 40 hours a week taking care of sick family members. 1 out of 5 people who takes care of a sick relative stops working. 30% lose their savings, file for bankruptcy. They're unable to continue working. This can have positive impacts. It can build relationships with family members with loved ones. It can create spiritual growth. It can create an increased sense of self-worth. It can give increased meaning to people's life. For some people, it is a natural fit and they find it very fulfilling. It's also very stressful. It creates social isolation. It creates a reversal of normal family roles. It creates a loss of intimacy. It creates a loss of personhood and individuality. It's very stressful. And through appropriate determination of care goals, care needs, and resources, sometimes that can be avoided or mitigated, especially by early involvement of hospice and palliative care resources. So who can get palliative care? Patients with serious illness at any age and any stage. People who need symptom management, symptom control, or goals of care. Diagnoses to consider that are sort of slam dunk, easy cases for involvement of palliative care. Dementia patients who've had aspiration pneumonia. Cirrhosis patients who have recurrent altered mental status. Breast cancer with malignant pleural effusion. Patients who are awaiting solid organ transplant. Not so much because their functional status may be that bad at the time they're awaiting organ transplant, but because in the U.S. our organ transplant system is complicated, and often patients die waiting for an organ transplant, unfortunately. Patients with decreased ADLs who aren't able to do things for themselves, patients who've had extreme weight loss, malnutrition, immobility, falls, frequent hospitalizations, patients who for a number of reasons have coded in the hospital. If you see a patient and your answer to the question, would you be surprised if this patient died in the next year, is no, it's not unreasonable to think about mobilizing palliative care resources. Or at least having that discussion, exploring that possibility with that patient. Now, when we talk about palliative care, we talk about concurrent palliative care. And I alluded to this briefly. It's care administered, aimed at symptom control, administered along with curative treatment or restorative treatment. And this shows a little bit of what that might look like. So in the white, you can see a time frame of anti-cancer therapy that's either curative, life-prolonging, or palliative, patients who'd be receiving chemo or radiation. The yellow box is intended to indicate the palliative, the symptom management therapies that the patient is receiving during that timeline. At the blue triangle mark is their 6-month prognosis, the time when someone feels that they have 6 months left to live. At that point, mobilizing hospice resources and identifying them as a candidate for hospice is appropriate. So they've been controlling symptoms, they've been doing curative or restorative therapies. It's now time to transition to solely symptom-directed therapy, to transition them to hospice. As they move towards symptom management and on to their death, the period after their death is really focused on their family. It's focused on the people they leave behind and providing bereavement resources to them. When we think about how early to get palliative care involved and whether it matters, there's a 2010 study that looked at in Mass General patients with non-small cell lung cancer who were randomized to early palliative care or no palliative care. The palliative care group experienced better quality of life, improved symptoms in terms of pain, dyspnea, nausea. They had less depression. They were less likely to receive aggressive treatment, defined as chemo or radiation. And they had a longer lifespan by 2.7 months. 11.6 months compared to 8.9 months than the group that had no palliative care. So they lived 3 months longer than the patients who had no palliative care. They had better quality of life, they felt better. And non-small cell lung cancer is not the only diagnosis we see that replicated in. We see patients feeling better, and because of that decreased stress and because of that increased quality, they live longer. And they feel better. It's certainly worth exploring. So when we think about who benefits from palliative care, we see here the figure on the top left is somebody who dies from sudden death. These are theoretical trajectories of dying. Someone who suddenly dies, probably not going to benefit from palliative care. Not going to do a whole lot for them. Top right, we have patient who has terminal illness. They're going to benefit from palliative care aimed at aggressive symptom management. They have a terminal illness that is causing them some symptom. We control it aggressively. When we see the patient in the lower left-hand corner, organ failure, where they're at a state of they're doing okay, they get a little worse, they get a little better, they get a little worse, they get a little better, with progressive worsening of their baseline over a protracted period of time. Those are the patients that we need to think about early involvement, to have those discussions about what their quality of life, what they want it to look like, at what point they want to continue treatment or not, at what point they want to keep coming to the hospital or not, and talk about what they want. Get a feeling of what their wishes are as their illness progresses and as their needs change. And having those discussions earlier prepares the patient, prepares their family, and can help them feel better. When we look toward the patient in the bottom right, the patient who has frailty, who is sick and weak and may not have a lot of symptom management needs, is there a role for palliative care there? Probably, maybe so. It may not be symptom management, but when we think of the psychosocial and spiritual support, there may be a role for involvement in multiple domains. There may be some family support that the patient needs. There may be needs outside of, maybe they're not in pain, but maybe they need some help navigating the system of healthcare needs as they approach the end of their life for whatever their illness is. So it's figuring out what the patient has, what they need, what they want, and how we can best deliver that to give them the best quality of life as they learn to live with serious illness and ultimately die with it. So how does palliative care help? It provides patients peace of mind. It helps patients better tolerate ongoing treatment, helps them understand their choices and have agency in decision making. They report improvement in pain. They report improvement in relationships and their psycho-emotional state. And it reduces caregiver burden and symptoms without increasing grief. So it doesn't make the family sadder. It makes them feel better. It makes them feel like their loved ones have symptoms controlled, that they feel better even as they die. So what do people want? What do you want at the end of life? Do you think about an ICU hooked up to a bunch of medicines and CRRT and absolutely everything we can do? Most people don't. That's not universally true, but most people don't. But they don't have a choice because they aren't given one. The conversation doesn't happen, and they aren't given the opportunity to say no. Like we talked about, half of patients in the last month of their life visit the ER. Most of them get admitted. Many of them die in the hospital. 2/3 of people want to die at home unless it's a burden to loved ones, but less than 20% of people die at home. Some people end up in the ICU and don't get well enough to leave. We can improve that some with better quality of care, but some of that is going to happen. It's patients we don't expect to get sick, who get sick and don't get better. And that's unfortunate. In some patients, we can see this signal down the line. We can see this 6 months ago when they came in with their 4th CHF hospitalization. We can see this when they came in and had to be placed on a dobutamine drip for 5 days before they went home. We can see this when they asked, hey, am I ever going to feel better? I don't know. Sometimes we can see this telegraphed before their last hospitalization, and those are the opportunities we have to step in and have those conversations so that they can get the care they want, and most importantly, not get care that they don't want. When those patients come in, it's important for anyone who participates in their care to have the conversation. You know, when you get sick like this again, what do you want to do? Do you want to come back to the hospital? Do you want to have these things done? Do you want to go through everything you went through last time? And the time to have that discussion, ideally, is when they're feeling better, when they're out of the hospital, when they have perspective on everything they've been through, and they're feeling kind of okay. But it's a difficult conversation to have, and it's a difficult conversation to have in people with serious illness. What are the things we need to discuss when we talk about patients and how aggressive to be with their care? Code status, of course. Goals of care. What do they want out of care? Pill burden. You know, are they taking 18 pills at home, and do they need to be? Do we continue treatment or do we stop treatment? If we're in a position where the patient discharges from the hospital, do we come back next time we get sick or not? Sometimes patients just need permission not to do more. They need permission not to participate in the medical system. Sometimes their families just need permission not to do more. They need to know it's okay not to treat everything as aggressively as possible if that's what their loved one wants. Again, our goal is not to eliminate aggressive treatment in every patient. It's to align treatment with patient wishes so that those patients who don't want aggressive care don't get it. How can we fix this? How can we fix the disparity between patients getting care that they don't want and not getting care that they do? Talking. We got to have those conversations. That's the only way to fix it. The only way to know what they want is to talk to them, is to have those conversations and to encourage them to tell their family members. If we have a conversation and find out what a patient wants, but they don't tell the people who make decisions on their behalf when they get hospitalized at a place that no one has ever seen them before, then it's up to the son, daughter, brother, sister to interpret what they think their family member might have wanted, which may be right or may be wrong. It's important to encourage patients to have those discussions with their family members once they've decided what they want, or to have the family members participate in their discussions as they're ongoing. So what do patients want? When we talk about what palliative medicine is trying to do overall, it's trying to control symptoms, improve quality of life while living with illness, ensure that treatments align with goals of care, support family, address physical, psychological, and spiritual needs, address the timing and location of care. So when is care provided? Where is care provided? Do they come back to the hospital? Do they stay at home? Do we have any patients in whom these goals would not be appropriate? No. This sounds like good medical care. This sounds like something that should be given to every patient. They shouldn't have to be dying to get treatment that aligns with their goals of care. Everybody wants to have quality of life while living with illness. So in palliative care, we're just taking good care of patients. Most importantly is symptom management. Patients want to feel better. These are the things that patients tell us are important. They don't want pain. They don't want to hurt. They don't want to be short of breath. They don't want to be scared. They don't want to feel sick at their stomach. They don't want to feel tired. They want to sleep. This is the most important thing that we can do to assure them that we're listening, that we know how to take care of them, and that we can improve their quality of life. This is why patients do better with hospice and palliative care, because they feel better. Relief of symptoms is the number one job so that patients and their families can focus on quality of life, so they can focus on doing the things they want to do, understanding that they have a serious illness. When we look at the symptoms that people have, again, pain, fatigue, dyspnea, depression, insomnia. Pain is across the board. It's not just cancer pain. Patients with COPD and CHF report up to 3/4 of those patients have pain. Now, is that related to the COPD or CHF? No, maybe it's related to those patients also have osteoarthritis or have had multiple joint replacements or back surgery, or who knows. But those patients report pain. That pain gets better with pain medicine. Those patients report fatigue. Those patients report shortness of breath. They report depression. They all have these symptoms, and when you make the symptoms better, they feel better. I want to talk very briefly about some of the common symptoms we manage in palliative care. Many of the treatment options in palliative care are off-label uses of medications because they haven't been studied extensively in those populations or for those uses. And in the pursuit of making people feel better, a lot of the side effects and potential side effects have not been deemed to be particularly important. Nevertheless, I will not be discussing off-label uses of medications or treatment modalities during this lecture, but understand that in palliative care and when treating patients with severe symptoms that impair their quality of life is paramount and takes importance over a whole lot of other things if that aligns with the patient's goals. And again, with every discussion and every medication that's used, it's a risk-benefit analysis. It's talking with the patients about what they want, what they value, and what's most important to them. If they have one complaint of pain, their back hurts, and they have 7 medications, none of them are working. Need to do something different. But if the pain is resistant to treatment, if it's resistant to high-dose pain medicines, it may be that something else is going on. Are there psychosocial or spiritual factors contributing to their pain? Are they struggling with something that they manifest as hurt, or that's the best way that they can express it? Consider involving our chaplains. Is it a spiritual problem? Is it something that they can't grapple with easily? It's a difficult time in people's lives, so it's something that there are a lot of reasons that people can hurt. In general, when we think about non-pharmacologic treatment, think about reversible causes, things that make people comfortable, positioning, heat. Non-traditional adjunctives, again, if it makes people feel better, probably not the worst thing. And evaluate for those underlying issues that may not be readily apparent. Emotional, social, and financial issues can cause a lot of pain and can potentially be fixable. Sometimes those are very difficult or impossible to fix. Sometimes talking about those issues, even if you don't have a solution, makes people feel better. When we think about the pharmacologic treatment of pain, one of the most important things to consider is an opioid rotation. If patients are responding to opioids and then are less responsive or developing adverse drug reactions, or if the medicines are too expensive, consider changing to a different medication with the understanding that decreasing the dose to adjust for incomplete cross tolerance is worth considering. In patients who are in pain crisis, the goal for those patients who are often admitted to the hospital or an inpatient palliative care unit for quick control of pain, the goal is symptom control over minutes to hours. Those are patients who are at the end of their life. They're hurting exquisitely, true 10 out of 10 pain. They're miserable. The goal is to get them out of pain. We know that oral pain meds and IV pain meds can be aggressively adjusted. When we think about how to do that, we look toward the pharmacokinetics of those medications. For oral opioids, it takes about an hour for those to reach their peak plasma concentrations. So the thinking is that if they're not effective at an hour, at their peak plasma concentration, probably that dose is not effective. Similarly, with IV pain medicines, they reach their peak plasma concentration at 10 minutes for morphine. If after 10 minutes that patient is not adequately controlled, it suggests that maybe they need a higher dose of pain medications. Again, that is for pain crisis. That's for getting acute pain control. Again, that's something that the palliative care team would be closely involved in here in the inpatient setting. Fatigue is a very common problem. Multifactorial, has a lot of causes across the illness spectrum. Treatment is mostly non-pharmacologic. It's energy conservation. Patients rest until they feel good enough to do something they want to do. They prioritize the things they want to do and devote energy to those. They exercise as they feel it. They make sure that they're eating. And you normalize it. You make them understand that they're going to be tired. It comes with the territory. There is a phenomenon called cancer-related fatigue that can be from cancer itself, that can be from the treatment of cancer and can persist after treatment. There are some medications that have been studied to be effective for cancer-related fatigue, but that data is still not robust. It can be debilitating, but can sometimes get better. Most of the time, it is energy conservation, prioritizing important activities, and normalizing that fatigue. When we think about shortness of breath, again, look at reversible causes. What I really wanted to bring up on this slide was the correlation between PCO2 and mortality. For patients with a PCO2 greater than 55, they had a 10% chance of death in their index hospitalization. So PCO2 greater than 55, 10% chance of dying, 33% chance of dying over the next 6 months, and 43% at 1 year. So those are patients to be cognizant of and in whom palliative care may be appropriate, in those relatively advanced COPDers. When we think about depression, this is a very important symptom in terminal illness. It impairs quality of life, can worsen symptoms, can worsen pain, can worsen capacity for pleasure. It can significantly impair how these patients go through illness. Sometimes you may have patients come to you and say that they feel like they're hopeless. That's not normal. Even in patients who are dying actively of a terminal disease, feeling hopeless is a red flag. It's probably worth treating. It can get better. If they get better, they feel better. Goals of care discussions don't cause depression. Talking to them about how sick they are and what they want doesn't make them sadder. It doesn't make them feel depressed. It often makes them feel like they're included as a part of the care team. It makes them feel like they're having agency in their treatment plan and that they're getting what they want out of the health system. Not sleeping is bad. Patients who don't sleep don't feel good. You can give them medicines to make them sleep better. I did want to bring up that there's a new black box warning for Ambien, Lunesta, and Sonata over the past couple weeks. Mostly in patients, I think it's only in patients who have the abnormal psychomotor effects, who do the sleepwalking and sleep activities. But the FDA just put a black box warning on these medicines. So since I was covering insomnia, I felt compelled to note that. But with all things, look for reversible causes. Look for things that would keep the patients up. GERD, rhinitis, anxiety, depression, substances, alcohol. Address sleep hygiene, all the normal stuff you do. When we talk about aggressive symptom control, when we talk about inpatient comfort measures, what we want to do is create a healing environment of care. We know that patients and families feel better when they are in a less clinical environment at the end of life. We want to provide emotional support and continuity of care. We want people who are caring for them, who are invested in the care of dying patients. We want them to see that they're seeing the same people who've participated in their care. I think here at East and in the Ascension system as a whole, our chaplains are integral to that part of the care process. A patient recently, I can't count the number of times I went by patient's room and saw one of our chaplains in there holding patient's hand, sitting at the bedside when no family was there, and it was just, it's incredible to see that level of care and commitment here on a daily basis, and I'm blown away by that. It's taking care of the patient and the family. Patients are our primary responsibility, but their families are just as much a part of being cared for as they are. And of course, symptom control, making sure that the patients are feeling better, making sure that they're feeling okay. The things that we can discontinue that make them feel less okay. When we're putting patients on comfort measures, they don't need many medications, they don't need labs, they don't need vital signs often, they don't need oxygen. It's not really going to help them. That's something that is a nuanced discussion to have with family, because some families feel very strongly about oxygen, they feel very strongly about IV fluids, they feel very strongly about nutrition. And those are individual discussions to have with individual patients with the understanding that we want to come to a consensus. In addition to symptom management, patients want direct communication. There were studies looking at cancer patients across multiple institutions, asking about decisions regarding goals of care while dying, discussions regarding goals of care while dying. Those who had those discussions had better quality of life, better outcomes for caregivers, and less aggressive care near death. The variation between those patients was not type of illness, it was not where they lived, what type of insurance they had, how much money they had, what illness they had, stage of disease. It was who their doctors were. The patients who had doctors who had goals of care discussions felt better, did better, had less aggressive care. The patients who had doctors who didn't have goals of care discussions, didn't have increased quality of life, had aggressive care, didn't generally have those discussions. It comes down to us. It comes down to people willing to have those discussions with those patients. And they're not easy discussions to have. It sucks. But it's worth having it because the patients need it. And if you don't do it, who will? Somebody might, but somebody might not. What's the benefit of communicating about prognosis and goals? End-of-life discussions are associated with lower healthcare costs in the last 30 days of life, lower odds of aggressive treatment near death, lower odds of emergency department and shorter length of hospital stay, greater use of hospice, and greater likelihood of death at home. Also less aggressive care. Including family in those discussions is also important, and taking into account cultural nuances for some patients, some families, and some cultures. Dying at home is not okay. Having these discussions is less okay. Having these discussions directly with the patient is less okay. Navigating that nuance is a challenge, and a challenge on an individual basis. The way we communicate matters. When we say things like, there's nothing more we can do, there's always something we can do. Even if it's not aggressive care, even if it's controlling symptoms, there's always something we can do. When we say, would you like us to do everything? It implies that the alternative is nothing, which it's not. The alternative is allowing someone to die naturally, which is okay. If you die, do you want us to bring you back? Sounds like a guarantee. And that's risky business. Do you really want us to break your ribs? It's a difficult position to have that discussion with brutalizing imagery to try to convince somebody out of doing something. But it happens a lot because we don't want them to go through it. We don't want them to suffer. There's a lot of data suggesting that it's perhaps not the best way to go about that discussion. But it happens all the time, and it's something that comes up a lot. And it's born out of a desire to help patients avoid things that we don't think will be helpful. Because we understand that the likelihood of successful resuscitation is less than 20% in the hospital and less than 10% in selected patients and close to 0% in certain patients. Patients and their families don't have that grasp because in modern media, in television and movies, the likelihood of successful resuscitation is somewhere around 60 to 70%. Dramatically different. One of the most important things that we need to do is learn to tell someone they're dying. Because if they are, they deserve to know. They can handle it. And people are far more resilient than we give them credit for. The sooner they know, the more time they have to process, the more time they have to align their wishes and the things they want to do at the end of their life and make sure that they're checking things off whatever list they have. Ask, tell, ask, I just wanted to bring up as a methodology to make sure that patients understand when we're having these difficult discussions, and the basic, it's ask, tell, ask. What do you understand? What have the doctors told you? Then you tell them the thing, the bad news, the prognosis, how they're doing. And then you circle back and say, you know, can we walk through what I just said? Sometimes I don't communicate well. Sometimes I have a really hard time talking through this sort of thing. Can you tell me what you understand? To be sure that in these critical conversations that they understand what we're talking about. Because some people, you come in and have the same conversation the next day and you realize they did not hear the same thing that you said. And this can help eliminate that friction point. When we talk about psychosocial needs, patients want to know what's going to happen. They want to know what's in store. They want to know who will take care of them, where will they be cared for, what will it be like. They want help navigating the healthcare system. They want help figuring out what to do next. They want help with the intangibles. They don't want to be abandoned. We underestimate our ability to heal and bring comfort even if we don't have a medicine to offer. Just our presence can do so much for patients. Just being there, knowing that they're being followed and taken care of and that someone is invested in them. It's important that we reframe hope, that we talk about the things that they hope for and make sure that they're hoping for things that are realistic given the changes in their life course and time frame. And that if we can do anything to facilitate those hopes becoming reality, that we do. If they're hoping to make it to a graduation that's next week and we can get them out of the hospital to do it, do everything that we can to. If they're hoping to make it to a wedding that's next year, unless we move up the wedding, we maybe need to reframe that discussion. Discussing expectations is the most important thing, letting them know what's going on, what's likely to happen, and where we're headed. Is this something that they're going to keep going in and out of the hospital with, and is that a thing they want to do? Is it something that's going to continue to get worse? Let them know where they're headed, let their family know, and see what they want to do. At the end of their life, people wonder why things happen. I don't know. It's not fair. It sucks. It's a hard thing to process, and helping them work through that, or having someone help them work through that is sometimes helpful. People have varying degrees of spirituality and religion. Having resources available, again, through our chaplains, who I can't speak enough about how helpful they are. It's an incredible resource to have, and helps patients so much when every goals of care discussion we have is hitting a brick wall, and they sit down with the chaplain for 10 minutes and completely change their minds. People want to bring closure to important relationships. Estranged relatives, people they haven't seen in a while that they have something important to say to. And there's a book called Dying Well by Ira Byock. And what he says we need to close important relationships with is 5 things. Forgive me, I forgive you, thank you, I love you, goodbye. And if we can help them work through some of those things at the end of their life, we should. Sometimes it's easy, sometimes it's hard. But we can at least start that conversation. And again, sometimes even talking about it helps them a whole lot. We have a lot to offer dying patients. While most of that is relief of symptoms, often more of it is who we are, a part of us as a person, and how we instill that into the care we provide and the love we provide as we interact with them. Sometimes patients come back to see us for the relationship rather than the remedy. If we can improve even slightly the end of someone's life or the burden on their family, it's incredibly rewarding and truly fulfilling. Thank you.